is focused on application of deep learning to a variety of medical image analysis tasks, including image classification, segmentation, and symbolics, especially for advancing cancer treatment in the head and neck region. Agustina will present paper titled Diagnostic Accuracy and Reliability of Deep Learning-Based Human Papillomavirus Data Prediction in Oropharyngeal Cancer.
Thanks a lot for the nice introduction. So I will present the work. This was in collaboration with University Hospital of Zurich, University of Zurich, IBM Research, and ETH Zurich. So oropharyngeal cancer patients their tumors can be driven by infection with human papillomavirus. And the one thing that happens with HPV positive patients is that they present a much better prognosis after radiotherapy treatments when compared with the HPV negative patients. So there exists a potential for radiotherapy treatment de-intensification or de-escalation for HPV positive patients. Current clinical practice for HPV diagnosis is P16 staining or more elaborate methods such as RNA in situ hybridization. Nevertheless, these methods come with some disadvantages. For instance, P16 has a moderate false positive rate, and RNA in situ hybridization is time consuming and costly. So in this study, we propose a deep learning approach to predict HPV status in CT of oropharyngeal cancer patients. We do not only evaluate the diagnostic accuracy, but we also evaluate the reliability of the method. And how we did that is, so we hypothesize that a model is reliable when it's looking at the planning target volume, that is the primary tumor and affected lymph nodes. So the dataset employed consisted of 3 collections, 1 internal from the University Hospital of Zurich and 2 public collections available at the Cancer Imaging Archive. This amounted to a total of 767 patients that were split into training set 60%, validation 20%, and tests 20%. And this was based on HPV status. That means that the 3 partitions had the same ratio of HPV positive versus HPV negative. This ratio was the one present in the whole dataset and was 73% positive versus 27% negative. So the pre-processing involved first the resampling to an isotropic resolution of 2 millimeters, and then a cropping was performed. And the way we did it was first we detected the nose slice. This was the most inferior axial slice that intersected with the most anterior slice of the head. And from then, once we had this starting nose slice, we selected the lung slice 96 pixels below. We also cropped the axial slices in the width and height dimensions by 96 pixels and 96 pixels again. And we did this cropping centered around the center of mass of the nose slice, so the starting slice, as you can see here. And also additionally, we set to background the 24th posterior pixels as they don't contain any useful information on oropharyngeal cancer, and we didn't want to confound the model too much. So next, the architecture we employed is a publicly available 3D model. It's called Genesis 3D Chest CT model from Models Genesis. So initially, this is an autoencoder that was trained on unlabeled chest CT scans to perform an identity operation in a self-supervised fashion. So from this autoencoder, we took the encoder that was pre-trained and added 3 fully connected layers at the end. So some training specifications, we used cross entropy loss with Atom Optimizer. To avoid overfitting, we implemented several things. So first, we didn't fine-tune the whole pre-trained encoder. We froze some layers, 15 from 27, and then we progressively unfroze those layers as training went on. We employed dropout between the fully connected layers, also early stop-ins. When the validation F1 score didn't improve in 50 epochs, we stopped training. We performed data augmentation on the fly, so small rotations, small elastic deformations to improve model generalizability. And we also used L2 regularization. In order to counteract class imbalance, what we did is that in each epoch, the model did not learn from the whole data set, but from a balanced subset of 20 300 subjects. And then the final model was selected based on the best validation evidence score. So as I said before, we also perform a reliability assessment, and how we did that was we generated class activation maps by two means. So a commonly employed method is GradCam, and also, which is a gradient-based method, and we also employed ScoreGAN. So in both cases, these methods, they employ the feature maps of usually the last convolutional layer, and they perform a weighted sum. So the thing here, the tricky thing is how they calculate these weights. So GradCam, as the name suggests, employs the gradient of the loss with respect to each feature map. Whereas ScoreCam, what it does, it gets the feature map, resizes it, multiplies it by the input, and performs a forward pass. And this gives you an idea of how important that feature map was, and thus that's used as the weight. So after we got the heat maps, we wanted to select the most relevant region that the model was focusing, right? So what we did was we thresholded those heat maps. We selected all the values above the 75th percentile and all the values above, 70th percentile and all the values above the 85th percentile. And then we computed these two formulas, these quantitative measures, with the planning target volume. So the overlap coefficient and the dissimilarity coefficient. So here, the results, as you can see, we achieved a very good performance across all sets. We suggested there was very or non-overfitting at all, as the test performance was very good. However, when we examined the overlap coefficients and the dissimilarity coefficients, we saw that while for the HPV negative predictions, there was some agreements to where the model was focusing on the planning target volume, so the areas we know they are relevant in HPV infection and oropharyngeal cancer, we saw that for those cases that were correctly predicted as HPV positive, there was a very low agreement with the planning target volume and where the model was focusing. So after visually inspecting, we saw, unfortunately, that our model, even though it had a very good diagnostic accuracy for the prediction of HPV positive cases, it was focusing on dental artifacts. Whereas, at least for the HPV negative, there was a good agreement between the planning target volume and where the model was focusing. So to recap, the aim of this study was to evaluate diagnostic accuracy and also the reliability of a deep learning model to predict human papillomavirus status in oropharyngeal cancer patients. We employed data from 767 patients. Our approach was fully 3D, and the input of the model covered the whole spatial context of the disease, meaning the primary tumor, affected lymph nodes. Transfer learning was performed for the model trained or CT images, which ensures the feature transferability when you perform transfer learning. And we achieved an excellent diagnostic performance, but unfortunately, the reliability analysis revealed that there was an increased focus on dental artifacts. So our data set was biased towards that. And nevertheless, we came up with this explanation, and we hypothesized that HPV positive and HPV negative patients actually have different socioeconomic profiles. So meaning that HPV negative is usually associated to drug consumption, alcohol consumption, tobacco consumption patients, which it's often linked to less money for oral hygiene care, meaning that these patients would not get dental implants. Nevertheless, however, HPV positive patients, their profile is just a more sexually active patient with no link to alcohol consumption or drugs consumption or any substance abuse. And these patients are usually more prone to take good oral hygiene and oral care. So yeah, this study had several limitations. So first, as most cases with medical image analysis, there was a restricted availability of labeled data. And also this labeled data was mostly, the ground truth was labeled with P16 staining. And as I explained before, this method has a moderate rate of false positives. So yeah, ideally, we would like to have a data set that the ground truth was obtained with the RNA analysis and not P16. Also, as I was just discussing, CT scans are very susceptible to artifacts. So maybe the inclusion of other modalities such as MR or PET would lead to a more informative diagnostic tool. And finally, we were lacking external validation. So testing how our model performs in an external hospital. So in conclusion, we achieved excellent diagnostic performance, but nevertheless, our model was being not reliable, as when we performed the reliability analysis, it was actually focusing on the dental artifacts for HPV positive cases, whereas good agreement was observed for in the prediction of HPV negative cases. The message we want to transmit with this study is that there's a necessity of performing reliability studies before any deep learning model is implemented in the clinic, even if there's an optimal diagnostic accuracy. So thank you very much for your attention. I'll be happy to answer any questions.
Thank you.
Yeah, no, not at all. That's also what makes it so difficult. It's not visible to the naked eye, or even a trained radiation oncologist is not able. Sometimes they guess, sometimes they're right, but no, there's no like radiological features you can see that. No.
Okay. It's the time limit. You tell me table question. So if you have any more questions, you can discuss it Agustina after the session. Thank you. Now let's move to the next presentation. The next presenter is Anna, who received her bachelor's degree in purification engineering from the Chemical University of Catalonia, Spain, in 2022. Currently, she is studying a master's degree in servicing at the Conservation Center in Barcelona. The paper she will present is titled Processing for Automatic Circuit